everyone. My name is Paul Jones. I lead strategy and operations at Foothold Technology, and we're thrilled to have you join us for today's conversation, the future of health home care, evidence-based management through data. The session marks an exciting collaboration between Foothold Technology and community care management partners, and we couldn't be more passionate about the discussion we're about to have. Just for context, Foothold Technology is a leading provider of human services electronic health record and care coordination software, and Foothold Care Management, or FCM, our care coordination solution, is used by 9 health homes across 237 care management agencies in New York State. CCMP is a health home in New York that leverages our care management platform, FCM, to support whole person care across the state. They are doing some groundbreaking research and work that's having a substantial impact on the landscape of health home care management. They utilize large sets of data, much of which is sourced from FCM, and employ data science methodologies and research to achieve new learnings and findings. This approach improves care coordination and significantly enhances the quality of life for thousands of New Yorkers. Today, we spotlight CCMP's efforts and showcase their strategies and findings. We're joined by CEO Nathan Ito-Prine and data scientist Tavin Weeda. Thank you both for being here today. I'm really excited about this conversation and really appreciate you taking time to join us. Maybe just to kick things off, can you both give us a brief introduction about yourselves and a brief overview of CCMP?
Sure. So thanks for having us, and it's great to be here. I'm Nathan Ito-Prine. I'm the CEO of the CCMP Health Home. I've been in the health home space and the care management space since 2012, actually care management space since 2011. I started in 2012 as a health home care manager. I worked 3 years as a health home care manager for the Institute for Family Health, currently one of CCMP's CMAs, actually was at that time as well. And then worked my way up through various quality, sort of started on the quality side, moved in the data side a little bit, then back to quality side, and then operations, and now CEO. And it's been an amazing journey. Gotten to see sort of all the different ways in which health homes needs to be supported in order to be successful, and what we can do to make it more successful in the future. So pass it over to Tavin to introduce himself.
Okay. Thanks, Nathan. My name is Tavin Weeda. I'm the data scientist at CCMP. I've been with CCMP since 2021. And when I first entered into the health home care management world, it was interesting to see these large data sets that everybody had access to, but a lot of people weren't fully utilizing the power that was behind them. And so as I came kind of into CCMP and to the health home care management world, I was able to start applying different data science techniques and analytics to these different structures and to produce different outcomes and analyses that just hadn't been there before. And it's been an interesting journey since my time being here. So I'm glad to be here.
Yeah, that's awesome. Thank you both. And I think that's a great leeway into really where I wanted to start is data really seems to be foundational into a lot of your operations and a lot of your research. And maybe you could double click a little bit into what that journey has been like. You know, you mentioned you saw all these large data sets, and what was the impetus for jumping into the data, and what, how has that journey evolved over the last few years?
Yeah, so when I came in, the first thing that I had noticed about CCMP is that as an organization, it was definitely already data driven prior to me even being here. CCMP was the only health home, to my knowledge at that time, that had started looking into its data to really see what outcomes our network was producing. And year over year, we started really driving towards these 5 different metrics that we were able to measure based off of our billing support questionnaires and also our annual comprehensive assessments. And these outcomes, looking at how CCMP overall had lower depression scores on PHQ-9s, had lower alcohol abuse on our audits, lower substance abuse on DAST. We were housing our members, and we were also reducing viral load amongst our members. So instantly, from the first couple of months that I was at CCMP, I was like, oh, we're looking at the right things. We're measuring this right. Now, as I started poring over the data and started getting more comfortable with the different sources that we were looking at, a lot of things were happening in the background. One of the big ones was in 2023, we had our budget fights where the state was trying to reduce the budget for health home care management by limiting enrollment length overall for members. And instantly, we kind of knew that this wasn't really a data-driven idea, but we needed to show why it wasn't data-driven. And so we started looking at our outcomes, and we asked the question of, well, how does it vary with health home enrollment? How do these outcomes change over time? And it really kind of spurred one of our first analyses of our dose response, where we were able to link health home enrollment with positive increases in those 5 outcomes. So we saw lesser depression over time with health home enrollment. We saw less substance abuse over time. We saw more members being housed. And really all of these metrics, the one message was clear that longer health home enrollment really leads to better outcomes.
Yeah, and there wasn't this drop off that the state sort of implied existed at the 9-month or 12-month mark, because they were trying to curtail enrollment after those periods of time, depending on acuity. So they wanted low acuity members, which originally were medium acuity members, because they did cut that low acuity rate, but they keep redefining things to make it easy to cut services. So the low acuity at that time, what was being called low acuity, was looking to cut at 9 months. That was DOH's policy position, that they were going to solve the budget issues by cutting at 9 months. So we wanted to see, is there any reason in the data for that? Does a person enrolled in health home reach their goals by 9 months, and then enrolling them any longer is just wasted money? Because that's the only reason I could think of that they'd want to cut it at 9 months, was that they had seen somewhere in the data that 9 months was a good marker of, okay, we've done enough, we don't want to spend this. But that wasn't the case. It wasn't even the case at 12 months. It wasn't the case at 18 months. It wasn't the case at 24 months. We saw, for most of the measures, we saw linear gains out to 36 months. So we took that data, and Tavin, you want to talk about what we did with that?
Well, with that data, we produced we had a bunch of advocacy that was done around it, that was getting passed around to the Health Home Coalition, trying to pass it up to the state at that time. And we also went to the care management conference that happened that year, and we presented on the data in front of everybody to show them that this is the pattern that we're seeing. This isn't based on what the state is saying. This is based on what is within our system and what we're seeing. And it really had, from our perspective, it seemed to, it did hit some of the right people at the right time during the presentation and during the advocacy that was being done.
Why do you, kind of double clicking into this, and also for folks who may be listening to this and not deeply familiar with the health home program and how it works, why do you think there was that continued linear progression, even all the way up to 36 months? Like, why do you think there was this, the longer enrollment period does drive better outcomes? I'm curious.
So I think there's a few factors. Number one is just the complexity of needs that our members have. This is not, it's not an individual just having one specific need that needs to be addressed and then they'll be stable. This is someone whose life has really spiraled to get them to this point. So, the average member enrolled in health home has a lot of comorbidities, a lot of physical, mental health, social service needs, and you can't just sort of address one of those and expect everything else to fall in line. And it's also, even once you do start addressing most of those, you've addressed those with the stability of a care manager. You've addressed those with that care manager involved. So it's important to also build the stability and make sure that the member, when they do graduate, is going to continue to see those gains. And it's also that so much of those gains are achieved through the relationship between the care manager and the patient. Being able to build that rapport, which takes time and takes in-person engagement, where meeting the member where they're at, meeting them in their home, wherever they want to be met, and having those in-person conversations and building that relationship, and then using that relationship to drive change in lifestyle, to reconnect them to primary care, to reconnect them to the specialists they need to be connected to get them taking their medications as prescribed, all those things. It takes time. It's not a quick intervention.
Yeah, no, that makes a lot of sense. I'm curious, and this might be, double clicking a little bit outside of the data, but more double clicking into the role of the care manager for those watching, learning about the health home program, or maybe deeply understanding why it's impactful. Can you just briefly provide an overview of what is that role of a care manager? What are they actually doing, and why is this sort of the ethos of what we're talking about here?
Yeah, let me start a little bit with the history. So, health home started in 2012 with the Affordable Care Act as a part of the Affordable Care Act's triple aim, which involved improving the quality of care received by patients, improving the health outcomes that they achieve, and then reducing the cost of care. And primarily that first part, the improving the quality of care received, was about moving care from outpatient to from inpatient to outpatient. So taking a lot of the members that start out with health home are completely disconnected from primary care, or if they are technically connected, they're not consistently going to their primary care providers. They're instead using the ER as their go-to, and it becomes very expensive, because when you're someone with a heavy burden of conditions, and you can almost always justify an ER visit. And so what you see is someone, let's say someone has congestive heart failure, a very common readmission condition. If you're someone with uncontrolled congestive heart failure, you live every day with chest pain and with shortness of breath. If you show up to an ER saying, I've got chest pain and shortness of breath, you're getting admitted. It's a guarantee. So being able to provide people like that with alternate avenues towards feeling taken care of and feeling, being able to realize that they can get in touch with someone who can get them in touch with their doctor, so that when they have those days where their relationship with their condition is shifting from I'm feeling on top of things to I'm feeling out of control, the only option isn't going to the ER. So generally, that's part of the purpose of health home care management, but it's achieved through small caseloads of between 15 and 50 members, intensive in-person encounters with patients, where you're going to their home, to their doctor's office, to wherever they want to be met, and engaging with them and building that relationship over a long period of time. So it's not like critical time intervention, where it's a short, immediate, few encounters and then pass them off to other services. This is about building that rapport, and then using that rapport to connect them to the services they need to be connected to and inspire them to use those services.
That makes a lot of sense. I have some follow-up questions on the ER, because I know there's some exciting research and findings you had on that front, but just staying
And we have
on.
some good news there.
Oh, I'm excited to jump in. One more question on the length of enrollment. I'm curious, was there anything that surprised you about your findings on the length of enrollment analysis, or did it track with what you instinctually knew? I'm just curious if there was anything that was surprising or uh, noteworthy um, for you all.
I mean, honestly, the thing that surprised me the most is how linear the gain was month over month.
That's what I was going to
To the
say. Yeah.
point that I kept double checking to make sure that I did everything right. Uh, but almost all of the graphs were just this straight line. There were a couple that, had different shapes to them, but that was the part that surprised me the most. That is there's a clear, defined relationship month over month that you can say every month you see X amount of increase, um,
Mm.
which is powerful.
That's powerful, right? I mean, getting that in front of folks, and I imagine, we can flash up on a slide, maybe a visual of the graph um, of that linear increase, but that is a powerful story of the power of the health home care management world and driving outcomes. Um,
And it was
wow.
great at that I'm sorry, at the conference, being able to present it to the people making the policy
Yeah.
recommendations to cut the service, and then having them be able to see it and then engage with them, about their questions about it, because they didn't know. I mean, the
Yeah.
problem was, for a while they weren't being fed the right information, and I think that
Mm,
the Department of Health is making strides to improve their data team. I know they've centralized a lot of things, and I've seen big improvements to how they handle data in their team. But without the right information, the policymakers can't make the right policies.
mm,
So it's part of our job to make sure they're getting that the information they need to make policies that actually improve care.
yeah. Just real quick, what were some of those conversations like at the conference? I'm curious how they responded when they saw that data, given that they didn't necessarily have access to that analysis prior.
It was great. I mean, it's one of the best things about working with Department of Health on all this is that they have really come in to all of these conversations, and every time we've presented data, they've been excited to see it. They've been
Mm,
excited to get the information. They've been ready and willing to use new information to make better decisions.
mm,
Um, they're not coming in a defensive place. They're
mm,
not coming in sort of trying to fight with us over whether what we have is correct. I mean, of course, they want to get clarification. They want to make sure that we're
yeah,
presenting accurate information, but they really are coming in with the right intentions and the right attitude to improve the program. And it's clear that they really do want to make a
yeah,
program that improves patients' lives and meets the other goals.
yeah. That makes a lot of sense. I want to jump into one of the other research projects and analyses that you've undertaken uh, with reducing ER visits. And I'll leave it at that. I don't want to steal any thunder. I would love if you can just provide maybe a little bit of background on the project and some of the methodologies you employed, and we'll go from there.
I can remember where I was standing when Tavin called me to tell me the results of this model he had built. I can remember I was at the foot of the stairs in my house, and Tavin called to tell me that he had just created a model that was able to accurately predict which of our members were going to go to the ER in the next 2 weeks,
Wow.
and that it was, and as we continued the conversation, it was clear that he was getting us around 6 times predictive power, showing that the members he was predicting with his machine learning model were 6 times as likely to go to the ER as an average member of ours. And it
Wow.
was like magic. I mean, this thing is predicting the future.
Yeah.
And of course, at that time, there was like, we got to keep looking into this. But we've gone so far from there. So, Tevin, I don't know if you want to talk a little bit about that journey.
Yeah. Oh, it's a journey. So, when I first started looking at this model, I was looking at it from a data perspective of we have all of this incoming data from various sources that FCM houses inside. And one of the ones that popped out to me was we're getting all of these alerts from the Rios that are coming in day to day. We're getting all of this like updated real-time data. And when I see something like that, that's when I notice that's something that is actionable. That's something that you can start applying different machine learning techniques to in order to try to create some type of outcome. Um, Now, with that being said, part of the impetus as well was when you look at health home care management in general, kind of some of the core ideas behind it is that, as Nathan kind of talked about earlier, is we're really a proactive healthcare solution. Like we are trying to connect people to their doctors. We're trying to make sure they're adhering to their medications, um, and then many other things that we're trying to improve their health overall. And when you look at emergency rooms, those really ring out more as reactive healthcare situations. It's somebody's not taking their medications, they're not going to their doctor, or other reasons as well. And so they end up going to the emergency room instead. And so, both from kind of this data side of this is something that is very useful and can be utilized, and also just from kind of some of the core mission of what a health home is, this seemed like a really good problem to try to tackle. Um, Now, this model was uh, developed over many months. All the data was sourced from Foothold Care Management. It uses uh, different types of variables. Some are static variables, some are more kind of dynamically updated variables. And as Nathan said, it uh, can produce a kind of simplified binary outcome that is saying, is a person going to go to the emergency room in the next 2 weeks? Yes or no? And it can do that for any time period that we want to look at, any 2 week window. And we've shown from time over time over time that it can do it for any 2 week window. We validated it over many different time windows over multiple years at this point. And it consistently will produce this 6 times more likely of a chance to go to the emergency room. To just elucidate a little bit, I said kind of static and dynamically updated variables, because these are really kind of the key to how this model functions. And I don't want to just throw words out there and not have people understand what they mean. When I say static, we're looking at variables that more or less kind of define or are characteristics of a person. Static will be like a native language. Somebody's native language doesn't change over time. Static could also mean in this context something like age, where age does change, but it changes very, very slowly. And to the model, it's something that's kind of set in stone. But we also have dynamically updated, and this is really the key point and why the model is so strong, is that it takes new information as it comes into Foothold, as it's entered into Foothold. So we look at new comprehensive assessments, which are done annually. We look at new billing support questionnaires, which are done monthly. We also look at new emergency room admissions as they happen. We look at encounters that are successful with a patient. So if a care manager goes in and enters that they had a phone call with a patient, that would show up in the model right now as you run it. So it's dynamically updated. And that's really the power of why this continues to successfully produce these high likelihood lists for every period that we look at.
Yeah, that's really the differentiator. There are a lot of models out there to predict ER and hospitalization risk in sort of long time periods using longer time periods of data. So your insurance companies will often look at what is someone's risk in the next year for going to the hospital, and they risk adjust those sort of things and use those to produce workflows. But they're using data that's claims data, so it's 3 to 6 months old at best, right? Like it's not fresh data because they take so long to settle.
Yeah.
So they are only able to produce those long window predictions, and they tend to just really be predicting the people that go to the hospital a lot,
Mm.
not sort of that person that is suddenly had an increased risk and they're going to go to the hospital once in the next year. They're really good at predicting that person that's going to go to the hospital 30 times in the next year. And if
Mm.
you think that's an exaggeration, no, those people exist.
Yeah.
So that's really what Tavin's model was able to do that is so different, was both short time window, a very actionable 2-week window, predict within that window, and it was able to do that because the data we're getting through FCM is so fresh. It's minutes old at the time
Yeah.
we're running these analyses. So access to that data, both directly from FCM and then the data that we get through FCM from HealthX allows us to run the analysis that Tavin runs.
Yeah. It really sounds like what was available before is really just lagging indicators of, you know, whether someone who already has a high likelihood of going to the ER getting readmitted, but this new model really took into account leading indicators. Um, I'm curious, once you built that model and just discovered that you were able to predict higher likelihood of ER admissions in the next 2 weeks, what did you do with that information?
Yeah, so that was the real challenge, right? We know what the future is. Can we change it? Um, so we went through a number of iterations of looking at different intervention workflows, different combinations of in-person or phone attempts. We mapped out a bunch of different models, looked at the cost of implementation, because that's really one of the things we wanted to build something that would be cost effective.
Mm,
Uh, it's not difficult if you throw a bunch of money at a problem to produce a good result, right? If we could create a $1 million intervention where we're spending $1 million in that intervention, we're going to see great results,
mhm.
right?
Yeah.
But it was about finding a very cost-effective intervention. So we narrowed it down to 5 different interventions, ranging from just making a phone call. Actually, no, ranging from the bottom was just saying, okay, let's just inform the care manager and say what they do. That was the sort of lowest tier intervention. That was like the free intervention, right? No additional cost to the care
Mhm.
manager's time, some cost on the CCMP end, but essentially free. And then the most expensive was you need to go and make multiple attempts in person to reach them and intervene.
Mm,
And we sort of found a middle ground that we thought really would work, which was a phone call. And if you don't reach them, another phone call. And if you don't reach them, another phone call, and on 3 consecutive days. But if you reach them, you stop. And
mm,
if you don't reach them on that 3rd consecutive day, you make an in-person visit. And if you again don't reach them, you make another in-person visit. So it was an up to 5 total attempts.
okay.
But we'd run the numbers and realized that the vast majority would be reached in person. So
Mm,
although in-person visits were a part of it, in-person visits are incredibly expensive in terms of time, right? Because
mhm,
you're not just meeting with the person for 15 to 45 to whatever an hour. It's not just the time, it's also the travel.
mhm,
Um, Getting to the person. I mean, some patients live an hour away from where their care manager is working.
mm,
So that's 2 hours of travel time on top of the visit.
yeah.
So we wanted to find something where we could get that intervention success a little easier. So we settled on that and we ran a pilot using that intervention model and paying an incentive to the care management agency for completing that intervention. And Tavin, do you want to talk about the results of that pilot?
Yeah, so in our pilot, we had 5 different care management agencies that participated in it of varying sizes, and in total we had 100 and it was over a 6 week time period. So over those 6 weeks, we had 3 different 2 week windows, and for each of those windows, we would run the model, produce
Mhm.
lists, and then we would share out the predictions to the care management agencies, and it would distribute down to the care managers. And they would go out, they would perform their intervention, and then at the end of the pilot, over each of those 2 week periods, we summed everything up um, uh, across the 5 agencies and also like individually, and also the pilot as a whole. We had 176 predictions that we had sent out.
Hmm.
Of that, we had 133 of those predictions that were actually completed. So that means that
Okay.
the care manager went, they either contacted them or they finished the 5 contacts. And during this process, when we found that comparing to the historical ED rate that we had calculated for the 5 different agencies,
Mhm.
and we found that during the pilot, we had a 47% reduction from the historical ED rate when a successful contact was made with the care manager or with the member.
Wow.
And so we were happy with this. And this pilot then allowed us to, it worked into a grant submission that we had been working on. It's part of why we did the pilot was for grant funding with this. Um, and we're currently in the process of that right now. But we recently did get our grant reviewed, and we made it into the top 6th percentile
Wow.
for grant
Congratulations.
submissions, and we're pretty hopeful that we're going to get funded at this point for this. So,
Would mean a 5-year rollout of this model across all of our HIV positive members in our network, and hope to expand it further from there.
Yeah. So just quickly, can you talk about what that might look like? What the future could look like with rolling this out? Maybe specific to the grant, but maybe more even broadly, what your vision would be.
So yeah, we have this model that is able to predict ER visits, and of course we want to use this for a few. We want to use this for a few things. One, we want to prevent ER visits that are unnecessary. So we want to be able to roll this out to our network. That has cost to it.
Mm.
So getting funding, securing funding that allows us to roll this out was big for us, to allow us to quickly get this to our network. But it was also important that this not end with CCMP, right? What Tavin created is incredibly valuable and is something that can be used not just in the health home space, not just in the New York State space. This is something that can be implemented across healthcare, and is something that we wanted to be able to propagate that and to create research that shows the value of it so that more people can benefit outside of just our network.
Yeah.
So this is a way for us to sort of put a bullhorn up in front of the work that Tavin's done and get it out to everyone and say, look, we've done something great. We want this to benefit the world.
Yeah. That's powerful. That's really exciting. And I think to your point, pretty much everywhere in the healthcare space in the US could benefit from that, right? Having access to that information, it's almost helping organizations, care managers, direct service providers work smarter. Like know exactly how should I prioritize my day? Who's at risk? How can we actually reduce both healthcare costs? That's incentive to the state and the government, right? But also improve their health, prevent something bad from happening, like actually
Mhm.
have that interaction. I'm curious, and this does jump back to the the role of care managers, but when you're talking with care managers or just in your time in that role, why do you think something like a phone call or a in-person visit, like what do you think happened? Like, why do you think there was such a significant reduction in ER visits?
Yeah, so and that's something that we've talked a lot about because it's really core to the question of why is this working? Why is this why do we design it this way? When we looked into the data, we saw historically that there was this connection between um, engagement with the care manager and reduced ER visit, even when it wasn't intentionally to cause a reduction in, what the meetings weren't designed to reduce ER visits, but they were reducing ER visits.
Mm,
And my understanding of where this comes from, is about the the way that our members end up in the ER is not necessarily the way that you or I might end up in the ER. If I'm ending up in the ER, it's likely that something has changed about my health, right?
mm,
Maybe I was out biking and got clipped by a car and have a broken leg. I'm going to the ER because I have a broken leg.
mm-hmm,
Um, so with our members, though, they're not mostly, they're mostly not having a huge change in their health situation. They're having a change in relationship to their health situation.
mm,
Um, as I talked about earlier, someone with congestive heart failure and that is not well managed has chest pain and shortness of breath as a baseline. That's their experience.
mm-hmm,
Um, so when they go to the ER, it's not because suddenly their chest is hurting. It's not because suddenly they're short of breath. It's because their ability to manage being in that situation, being in that condition, has shifted in some way. And so my belief is that being able to have someone that you can call and sort of feel connected to, and someone that you can speak to, um, or someone that calls you, even better. If someone calls you and connects with you and asks you how you're doing, is able to work with you on what your concerns are, removes that need to suddenly go to the ER because relationship with your condition has deteriorated. Right? If your background stress of I don't know if this pain that I'm feeling means I'm dying, which is, that's a concern that someone living with CHF is going to have.
mm-hmm,
Um, if that stress is sort of slowly ratcheting up throughout your month, and if you don't have someone to connect with who's able to say, okay, see, this is bothering you. Why don't I get you in to see the doctor, to
mm,
see your primary care physician who you also have a relationship with,
mm-hmm,
um, is able to change the trajectory of your care. And it's about that relationship that the care manager has with their members. Um, Being able to lean on that rapport is I think really key. So
mm,
that's my concept. And I know there are some other theories out there, but we've really seen that relationship that a care manager has with members is really key. And it doesn't take a finely tuned intervention. It takes a connection between two people with a rapport.
mm-hmm. Yeah, that makes a lot of sense. And I think this almost drives or connects back to the conversation earlier, right? Like there's a linear increase. I imagine so much of that is also as rapport is increasing, there's, mm, I don't want to oversimplify it to say like outcomes are driven as rapport increases, but like as a care manager works with an individual over a longer period of time and really builds that trust and rapport and relationship, some of those deeper issues that take time to work through and to
Mhm.
to move forward, that they're actually able to really trust and work with the care manager and maybe go to an appointment that they were hesitant to go to 6 months prior and maybe try a medication that they were nervous about before because they really trust that care manager, and that duration really improves the outcomes over time, I imagine.
Absolutely.
I want to be mindful of time. I want to just shift a little bit into forward thinking and just one big conversation about data. But uh, one of the things that happens, or I've seen happen, is data can sometimes be a big and scary word for some folks out in this ecosystem. And there's data sources here and data over there, and you know transparently, at Foothold, we've been investing a lot in data and making data accessible, but that, you know, in this ecosystem, data is not always readily available. And I'm curious, just, outside of FCM or even within FCM, like, what are some of the challenges you all have faced when it comes to getting access to data? And maybe what are some of the things you're thinking about more broadly? If you're like, oh, when we get access to this data or when we start thinking about this will unlock XYZ or allow us to explore XYZ.
You want to take it
Yeah,
first, Tavin?
yeah. So, kind of as you said, there are a lot of data sources, and each one has different levels of access to it.
Mm,
Oftentimes, what you will find though is that a lot of these data sources are sort of walled off, where I may be able to go in, I may be able to look at like, read someone's chart, but I can't get that chart in a format that I can then analyze later on. Or I
mm,
may get like an aggregate of our entire population, but I never get. It's a lot harder to get like member level detail in whatever source you're in, whether that's UAS, whether that's psyches.
mm,
You keep going on with that list. But what we've been really doing is, rather than say, oh, we don't have access to this, we decided to just start reaching out. And over time, we've started developing different relationships with these organizations and have started doing more direct transfers of data from their systems into our environment, into CCMP's environment. One of those that we have going right now is with UAS, which already had the infrastructure in place, but we do get children's HCBS and CANS data directly sent to CCMP's environment every morning. So whenever a new assessment is done, it just gets sent directly to us. Um, and what this really allows us to do is to, just like we did with our outcomes data uh, that was within FCM, is now we can take CANS level data and kind of apply the same methodologies to it and say, well, we see that this pattern of care drives this change in CANS over time. We see that this one doesn't drive it as much. And we can show also how um, our children's program, in this specific case, does have improved outcomes over time. Which is what we work on. But with that, we also have been working with psyches as well
mm.
in order to get that kind of line level data sent to us for kind of a similar type analysis, and Healthix as well to receive other data that isn't um, that we don't have that kind of line level access to.
Yeah, and then claims data from DOH. The one thing I'll add to what Tavin is saying is that none of this would have been feasible if we weren't already showing results.
Mm,
It's the easiest thing to do when you work with data is to complain about your data sources.
mm,
Um, Everyone loves to say, well, if I had access to better data, I would produce better results. And it's true. I mean, it's a common complaint because it's true, but it is also something you can't let completely handcuff you,
mm,
or no one's going to have faith to give you more data. No one's going to want to give the person that isn't producing results more data to work with.
right.
So we had to first take what we had and produce results.
Hmm.
Um, and so that's what we did. I mean, in 2018, we were producing results. Actually, I think it started a little, yeah, around 2018, we started producing the outcome results, which no one else yet at that point was producing, really detailed outcome results for Health Home. And we were showing that to the state, and that really jump-started a conversation that we'd been having since 2015 with the Department of Health to say, look, if you give us better data, we'll produce even better results. We weren't going to start getting that if we weren't already showing those results. So being able to continuously move our own analyses forward, independent of what we're getting from external collaborators, is key to building the confidence of external collaborators that if they go through all the effort, because it is a lot of work for them to get that data to you, you need them to know that they're going to get something for their work, or they're not going to want to work with you. So being able to get information to them, to work with them and show them what we can do, has led to a strong rapport with them, and has led to them having faith that when they do give us stuff, we'll produce more interesting stuff that they can then use, right? We're not just taking this and keeping it to ourselves, we're sharing it back to them, which they can use for policy, for decision making. So yeah, building that faith so that we can have a collaborative relationship is key.
Yeah, that makes a ton of sense. I guess my question in closing, and Tavin, you may have alluded to this, is what's next? I know there's this potential grant funding. Are there particular questions you're exploring, as well as, you know, a next phase of research or experimentation or learning? Or is the way you all operate, there's a continuous slew of learnings and analysis happening, and as things or abnormalities or interesting things poke up, that spurs deeper analysis? I'm curious.
Both, for sure. Um,
Makes sense.
yeah. Yeah. So there's, always things that are happening, always questions that may pop up that we may react to a little bit. But then we find out something really cool that we didn't know before. But in terms of more planned out things, the buzz now is that everybody's working with LLMs, and that's something that we've started working with at CCMP. And
Talk what an
it's
LLM is.
a large language model case. So we've started looking at that, and we have a couple of project ideas that will use the different encounter data that's inside of Foothold to produce various projects that we do have eventually that we will work on, and hopefully we'll have a result that will be transformative to the health home landscape.
If I can just further talk a little bit about that. So one of the frustrations of data access in health home space, and I imagine in any place in healthcare, is that you want discrete data elements, which are data elements that are in and of themselves reportable. You can report on just that information, pull it out and do analysis on it. But whenever you build a report or build a assessment or anything in the system that requires the line level staff, the people directly interfacing with patients, to fill something out, there's a trade-off. You're reducing the care that they can provide in other places so they can provide, fill out more reports. And there's a burden. But there's all of this encounter data, which is just free text. It's just, free flowing information there's tons of it. And being able to take that and turn that into actionable data that we can run reports and learn things from is what these learning language models are able to do.
Interesting. So it's almost codifying elements, like for instance, of encounter notes. So if I'm a care manager and I, am meeting with them and they're sick and they are, or maybe on the flip side, they're actually doing really well. They have a fully stocked fridge, and maybe I'm like, writing out a whole list of encounter notes. It's essentially codifying like food elements, and like you can like codify different pieces on that. So you're like, okay, we want to run a report on XYZ based on encounters. You can't really do that with free-form text, but being able to codify that and then analyze it, that's really cool.
Yeah, it'll open up a lot more information to be accessible to us.
Yeah. Well, y'all, we are at time. This has been such a great conversation. I'm really appreciative of both of your time, and, really excited about the work you're doing, and know that it has broad implications, not just within New York State, but I also hope that this, gets out into the nation. So really, thank you all so much.
Yeah, thank you. This has been a lot of fun.
Yeah.